The second drug we are exploring is isoniazid. In 1951, 3 pharmaceutical companies each independently discovered isonicotinic hydrozide, later renamed as isoniazid, as an anti-TB agent. It was more effective and had less side effects than streptomycin, which was previously the main treatment used against tuberculosis. In addition, isoniazid was not difficult or expensive to produce. For active tuberculosis, the current regimen is for 2 months with isoniazid, rifampicin, pyrazinamide, and ethambutol, followed by 4 months of isoniazid and rifampicin. For latent tuberculosis, isoniazid is typically given as a monotherapy to be taken daily for 6 to 9 months, but this has been associated with poor adherence rates and the potential for toxic effects. To alleviate the toxic effects, it is usually taken with vitamin B6 or pyridoxine. Isoniazid works by inhibiting mycolic acid synthesis, which are essential components of mycobacterium cell walls. It is bactericidal in rapid dividing mycobacteria, but it is bacteriostatic if the mycobacteria are dormant. Isoniazid has a unique pharmacokinetic property. The primary metabolic route in which isoniazid is eliminated from the body is via acetylation, and this is affected by gene polymorphism among different ethnic populations. For instance, Indians are slow acetylators of isoniazid, while Chinese are fast acetylators of isoniazid. Despite the beneficial effects of isoniazid, there can be some severe adverse effects, such as drug-induced hepatitis, skin allergic reactions, and neurotoxic effects such as peripheral neuropathy. By administering pyridoxine, especially for special populations such as breastfeeding mothers and malnourished patients, pellagra and peripheral neuropathy can be prevented. Isoniazid interacts with other drugs as well. Due to inhibition of hepatic microsomal enzymes, drugs such as phenytoin and carbamazepine has their metabolism rates reduced. When isoniazid is taken with alcohol and rifampicin or pyrazinamide, there is an increased risk of hepatotoxicity as well. The use of aluminum salts also reduces GI absorption of isoniazid. Thus, isoniazid should be administered at least 2 hours before any aluminum-containing compounds such as antacids. In summary, isoniazid works by inhibiting mycolic acid and cell wall synthesis, and killing the bacteria and stopping its growth. However, liver function and neurotoxicity has to be monitored when taking isoniazid. In addition, isoniazid decreases vitamin B6 levels, and thus, patients taking isoniazid would need to take supplementations of vitamin B6 to alleviate pellagra and peripheral neuropathy, especially for special populations.